But now I'm going to turn the mic over to our esteemed colleagues. First, we're going to have Dr. Rosa Vega, who is from UCLH. She's a very experienced interventional endoscopist. She's the deputy of the bowel cancer screening in Northern London. So now I'll turn it over to you, Rosa. Thank you.
Thank you, David, and good afternoon, everybody. I'm a consultant gastroenterologist, as David said, at University College Hospital just down the road. And I am the lead for all the interventional endoscopic procedures that happen in the large bowel in the hospital. And hopefully, within the next 10 minutes, I'm going to give you a bit of a reality of what we face as doctors. And with the slides that I have prepared, you will see my journey in order to help the patients without causing harm. That is always something that we want to do. Now, let me see if I can work this. The next slide will be that. So, as I said, I deal mainly with either precancerous or cancerous lesions in the colon. And bowel cancer is a very common type of cancer. We would say is the fourth most common cancer in the UK, and the second most common cancer that causes death. And in the UK, we have 69.23 million population as last month. How does the cancers appear? When I say bowel cancer, for those of you that maybe have forgotten a little bit about biology, the bowel cancer usually originates in the large bowel and starts with a benign polyp that when you have your diagnostic colonoscopy, sometimes you have removed. And if these polyps are not found or removed, it takes about 10 to 15 years of multiple changes in the cells and the genes and nuclei of the polyp to develop into an invasive cancer that unfortunately the only cure is to remove the bowel surgically to get rid of the disease. Now, when you have surgery, it obviously cures you of the condition. However, surgery can be quite mutilating and sometimes leave patients with long life-lasting consequences that affect their quality of life. For instance, if your bowel gets formed in the left side of your bowel, and this is the area that needs to be removed, most likely, if the cancer is very close to your back passage, you will need to have a stomach bag in your belly in order to produce your feces on a daily basis. And obviously, your cancer is cured, but quality of life is affected. Also, having bowel surgery comes with complications, and sometimes things can go wrong. And our surgical colleagues do a great job, but they are major surgeries. And this is the data published, that is in the public domain in 2020, of the outcomes that happen at University College Hospital, where my colleagues are highly experienced and do a fantastic job. But as you can see, they do nearly 400 operations of bowel cancer a year, of invasive cancer. The mortality rate is about 1.7%. Usually patients stay more than 5 days in the hospital, and patients may need to come back within a month in about less than 10%, but still it creates a lot of pressure in a very busy NHS setting. And obviously, they are already doing 400 operations a year of these invasive cancers. So if there is something I can do to take some of these cases away in early cancers that I can remove endoscopically, that's going to reduce pressure. Now, when we diagnose bowel cancer in the UK, most of the diagnoses happen when patients have developed symptoms. However, there is a 10% and is on the increase because of all the public health promotion or so forth, that cancers are diagnosed through the bowel cancer screening program. For those of you in the UK, you may know that the bowel cancer screening program here invites individuals to participate on the screening between the age of 50 and the age of 75 by doing a stool test, and if the stool test demonstrates presence of blood, then you have a colonoscopy. Most of the patients have not developed any symptoms at all. It's just through the analysis of this test that the colonoscopy is done. And when we diagnose these cancers on patients participating on the screening, what is very interesting is that most of these cancers are on a stage 1. What it means, it's an early stage, and there are things that can be done endoscopically to cure these cancers without the need of performing surgery and leaving the patients with long-lasting quality of life problems afterwards. So, because of that, the European Society of Gastrointestinal Endoscopy has recognized that endoscopic treatment of large complex precancerous polyps or cancers need to be treated slightly different if they are on a very early stage. And for the very first time a couple of years ago, recognized in their guidelines that an endoscopic submucosal dissection would be the mode of removing these early cancers in patients that fulfill the criteria. And now I'm going to explain to you what is exactly an endoscopic submucosal dissection. Here you have a diagram of what the bowel looks like, right? Our feces travel through here. That's the inner layer of the bowel, and then we have several layers until we reach the muscle. So early cancers or complex polyps, they develop in the inner layer of the bowel and progress through the stages until they invade the muscle and go beyond the bowel wall. I think it's clear, right? So when we are performing an endoscopic submucosal dissection through a colonoscope, so these flexible scopes that we can introduce inside patients' bodies in a colonoscopy through the back passage, we are feeding instruments to allow us to peel whatever is happening. That would be the inner layer of the bowel, that would be the muscle. So with our devices, we can peel between the muscle and the inner layer of the bowel. So if there is a complex polyp or a cancer that I have represented here with a star, it can come out all in one piece, but still preserving the bowel wall. Therefore, the patients can recover much faster, don't have any they don't have a major surgery, and they can do better and regain their functional bowel as they would. But what are the sort of challenges of doing this procedure? I have explained it to you in 5 minutes, but it's an extremely slow technique to learn. First of all, because we are working in a very complex, difficult organ that is a bit bendy. Secondly, because we cannot peel it with our hands. We need to use instrumentation that is about 1.5 meters away from our hands. And we are peeling areas that are only between 2 and 4 millimeters of thickness. And if we go a bit deeper, what happens is that we cause a perforation, and then the patients need to have emergency surgery. So we have to be extremely slow, and the learning progression, unfortunately, is not very quick. As David and I think Craig mentioned, these techniques were first described with success in Japan. In Japan, the prevalence of cancer in the stomach and the gullet is quite high. So the doctors in there were able to learn to do these techniques in 2 organs that they are a bit thick and they are straight. Therefore, you can practice in an organ that is easy to do. Unfortunately, or fortunately, depends on how you see it, in the Western countries, the cancers in the stomach and the esophagus, the gullet, are not so prevalent, but we have a lot of complex polyps and cancers in the bowel that we need to deal with. And if we have to wait to learn practicing our skills in the stomach, probably we won't ever learn to the level of sufficiency, so we have to learn in the most difficult and complex organ that we have available. So, how did I come with all this venture? Obviously, I was seeing more and more patients that cancers were diagnosed in early stages, that doing a surgical procedure was probably a bit too much for them with the complications and mortality rates, and removing these polyps not in the right way to peel the polyp completely or the early cancer didn't sound right either. So, there were lots of monopolar devices, as they have mentioned before, that they do the job in skillful people that had been done that for 20 years in Japan. But these monopolar devices, the type they deliver the energy, can cause harm if you touch the muscle, and you can potentially perforate. So I didn't feel extremely confident to learn, and I didn't have, in my specific individual case, the opportunity to drop everything at UCH and say to all the patients, wait, I'm going to disappear for a year because I need to go to Japan to learn, and then I'll come back. And then Creo, and it's a reality. There are quite a lot of my colleagues that were able to do that, but in my case, I couldn't. I had a lot of patients and things to deal as other venues I do at UCH. So Creo Medical approached me just to say, we have this new device that delivers different type of energy. We combine bipolar radio frequency with microwave. We think it can be safe to patients for the way we deliver energy. Learn with it. And I thought, why not? So the difference in between the two types of energy, just for you to be quite clear, is that when you use a monopolar device, it means you have a little positive cath that delivers electricity. You have to have a receptor at the end of it. There is quite a long journey, and in between you need to cut some tissue. So the amount of energy that you deliver is not very controlled because you need quite a lot of it. Whereas when you have a bipolar device, means that in the device itself is the only journey the energy travels. So it can be much more controlled, and you can decrease the energy by 1/10. And when you are using microwave for coagulation rather than radio frequency, is exactly the same. Microwave, everybody has got a microwave at home. You may overcook a bit tissue, but it never becomes carbonized, right? So it's the same in here. You can create a coagulation just by increasing 90 degrees of Celsius of temperature, but you don't burn. And that's why it makes it also safe. So in 2019, I had my first training course with Creo Medical, that they had a very structured training course with very good syllabus, and then mentoring afterwards. I was able to put a business case together in the hospital to say that makes sense from the cost-effective point of view and also from patient safety point of view. And I did my first case in September 2019. And I was lucky enough that the whole endoscopy department didn't close, so I could continue doing some cases despite the pandemic years. So I just going to show you a quick clip of 2 minutes of what exactly an ESD is about, so you can sort of get it. So here you can see that's normal bowel, and in here you have a very complex, very flat polyp across the bowel. And what I'm doing with the speed the boat device that you can see here at the end of the scope is just demarcating the area where I need to cut. What I have created here is a blister of fluid with a bit of blue dye to help me to highlight what is polyp and what is normal bowel. And very slowly I am disconnecting the inner layer of the bowel from the deeper layers and the muscle. So very slowly opening here a window and just peeling nicely and controlling, and if there is a bleed, I can do. So I have already created a tunnel. This white bit is the muscle. I have the polyp here on top of me, and I am continuing to dig deeper in between the muscle layer and the inner layer of the bowel in order to keep peeling the polyp away from the muscle layer. And you can see it cuts very nicely. There is no carbonization because of the way the energy is controlled, and that also increases very nicely the visualization because you can see at any point what you need to cut. Now I just need to connect the sort of two lateral sides that are still attached in here, very slowly and very precisely. It's all very neat. There is only this segment here that needs to be dissected. And very soon you will see that's the last strength that I need to dissect. This would be what the bowel continues. And now I'm cutting through the other side, and you can see blood vessels in here. I'm using the microwave just to coagulate them. There is no carbonization. They just get blanched very neatly with no bleeding whatsoever. And this is the polyp that I just peeled, that we analyzed, and is a very early cancer, and the patient was able to have a curative treatment without the need of surgery. I've done a total of 275 cases since 2019 with lots of very good outcomes. You can see polyp diagnosed, polyp resected, in the piece of cord to be analyzed, and how it looked 6 months later. And lots of, I just put here a small example of a patient testimony, many of patients being very, very grateful, especially for those patients that we save a mutilation surgery going forward. Since I have a passion for training and mentoring and trying to spread this technique skills to the rest of people in the UK and further afield in Europe, because I think from the patient outcome, safety and satisfaction point of view is great. And I have participated in many life endoscopy courses, and I continue mentoring young colleagues to adopt this type of surgery in order to be more of us that can do this type of procedures. We have also produced, Creo Medical is helping with some funding at University College Hospital in order to have research fellows that can help putting data together. Because when we are NHS physicians, we are incredibly busy with everything going on. So having people managing data also helps quite a lot. And that's been very important in order to produce data there. We have presented several already research projects in our international prestigious meetings, where we have demonstrated that we have incremented the number of cases that we do every year, because obviously there is an increased flux of referrals, and we become competent, and I can train other colleagues that can take cases on board, so we can do more and more cases with very good outcomes, with very low profile of complications. We are below the sort of international average with a 2% perforation rate, which is really, really good, because 275 cases may sound a lot, but they are not so much. So it's not so many cases that are done so far. There are people out there in the world that have done more, and my quality performance indicators using this device really are translating to be a very safe energy to use in my hands. We have also produced data in terms of our cancers and the cancers that we have been able to cure just with an endoscopic procedure and avoiding patients having surgery. Obviously, we have been able to resect 25 of them, and then once we resect, the cancer is down to the analysis of the type of cancer to see if any further surgery is needed, if there is some suspicion of possible metastasis. But at least we can produce a very good quality histology that can give the chance to patients not to have surgery. We have published also case reports. That's a very interesting patient. It was, even if it's not very well described, an emergency endoscopic submucosal dissection. A patient in her mid-60s that had a very large polyp in the lower end of the bowel that keeps secreting a lot of mucus. Therefore, she was developing renal failure because of the amount of fluid that the polyp was secreting, requiring being in ITU several times despite replenishing the fluids. And we squeezed her in between because obviously she was in and out of ITU because of renal failure, the kidneys failing. And we managed to remove this 14 centimeters lesion from the lower end of the bowel safely in 6 hours, which is not a very long time for such a big polyp. And actually the patient recovered very well and never had any problems with her kidneys anymore. So lots of successful stories. So my collaboration with Creo Medical nowadays, obviously I am a member of the Innovation Council that I run, that Charlie chairs, and I provide my clinical input in order to develop new devices that can adopt this type of technology to make endoscopy therapy safer. I also a trainee on the Pioneer program where we train other doctors and mentor other doctors in order to adopt this technology, and obviously wishing that this technology is helping more and more interventional endoscopists to be able to train in this type of procedures. And my final thoughts before I stop is that I think with the current climate that we need to do interventions that they are cost effective, that we can shorten, especially here in the UK, NHS setting, the length of stay, and that we can keep good performance indicators and patient satisfaction. I think the devices from Creo Medical align with this type of thought, and basically happy to continue collaborating with them because it has provided very safety platform for me to keep treating my patients.